Father, thank you for this day. Thank you for the privilege of being here, privilege of serving our Cherokee people, but also the privilege of serving you. May we always be mindful that we are accountable for our words and for our decisions. And we thank you just for the ability to be here, each and every one of us arriving safely and to conduct your business. In Jesus' name, amen. Roll call, Shelley.
Yes, sir. Mike Dobbins.
Here.
Keith Austin.
Here.
Harley Buzzard. Sean Crittenden.
Here.
Julia Coates. Here. Joe Deere.
Honey.
Kanan Duncan. Rex Jordan. Daryl Legg.
Here.
Wes Snowfire. Dora Petkowski. Here. Murray Bakershaw.
Hey.
E.O. Smith.
Here.
Janice Taylor. Here. Victoria Vasquez. We have a quorum.
Thanks, Shelley. Moving right on to reports, we'll move on to Miss Lisa Pivick. Lisa.
Good morning. It's nice to see all of you again. Haven't seen you in quite a while. So if it's okay, you do have my report in front of you, and I'm going to go over just a couple of things if I can share screen. And then I'm going to turn it over to Dr. Gann for the COVID update. But mine is a little different. So I'm going to go ahead and share screen now. And it's the same material that's in your report. I just want to highlight a few things. So 2020, we're getting back to work now on most of the things that we put off in 2020 that due to the COVID response. So I wanted to highlight a couple of things from 2020. I usually give you an annual report in January or February of accomplishments, and I did do that, and I want to highlight a few things. And this is up till February the 7th of this year. We did 14,435 case investigations and 10,386 close contacts and followed those persons. Those are persons who were in contact with a positive COVID patient that we followed for 14 days. We also did 150,261 daily follow-up tasks, which include daily phone calls, check-ins with cases and close contacts. The epidemiology team has produced data reports on a daily, weekly basis, and Dr. Gann can talk about that a little more. We've managed 5 COVID-specific cooperative funding agreements from federal agencies. Some of our staff has assisted with food distribution efforts, screening at the complex, and preparing guidance materials for schools and workplaces. And we've done 20,648 COVID-19 hotline calls. That includes the EPI line. And then the actual COVID-19 hotline, we started taking those calls on November 9th. So what I mainly want to talk to you about just a little bit today is the 2021 outlook for public health. We're obviously going to continue our COVID response efforts. But at the beginning of February, we started to return to planning for other things, working on other initiatives. And one of the main things that we have to do this year, we're up for reaccreditation this year with the Public Health Accreditation Board. So we need to update our core documents to ensure competency there are new updated 10 essential services of public health that came out in 2020 that feature equity, and the FAB standards and measures is version 1.5, and we were accredited under version 1.0. And in updating those documents, we have to do tribal health assessment that leads to the tribal health improvement plan. And the tribal health improvement plan is the one in which we get a significant amount of community feedback on the plan that we're going to work on activities in the community. We are planning to continue all our current cooperative agreements and ensure compliance with agency guidelines. Right, cooperative agreements are also, you may call them grants. The only difference is in cooperative agreements, the funding agency has obligations to you as well, and you sign that agreement. And we have right now 17 of those that we're managing across public health. We're going to resume working on our county health profiles. Based on what we stopped working on when COVID hit, we were working on doing those county profiles based on the physical activity survey. And since that time, OU has analyzed a great deal of our Cherokee Nation Health Survey as well that we can include in those county profiles. The last thing that I want to mention to you is if you look at the things that we're working on, one of the main things that we have to get done before we do the tribal health improvement plan and the tribal health assessment is a strategic plan for public health. We have finished the draft of that, and I just submitted it for approval through our internal governance structure in health. And as soon as that is input is taken and it's revised and it's approved, I will be happy to provide you with a copy, which I anticipate to be in the very near future. And I'm going to stop right there because I know Dr. Dan has quite a few slides to update you on with COVID, and then we can take any questions if that's okay.
Go ahead, Dr. Gann.
Sir, thank you. Good morning to everyone. Make sure I share my correct screen. This one. So it's not that many slides, but I'm going to just go over briefly the status of COVID-19 in the United States and Oklahoma and locally, and talk a little bit about what we're doing. Let's see. So in the United States, the numbers have gone down tremendously since the beginning of January. You see, this is where we got hit hard after Christmas nationally, and our hospital capacity peaked out, and we suffered greatly. We've kind of hit a plateau in the U.S. at about 70,000 cases per day. These data are through yesterday. The new data today shows the same thing. It was continuing on this plateau. The deaths have started to go up again just a little bit over the last couple of days. I don't know if that will be a sustained trend. I doubt it, just because the number of cases are going down or plateauing. Those deaths should stabilize. With the weather we had last week, it just kind of threw the numbers off a bit. So we'll see how that develops. But we're averaging still over 2,000 deaths per day in the United States. And here's the country. If you recall, red is the worst when you're over 25 cases per day per 100,000 based on a 7-day average. Orange is the next lower category than yellow and green. See, Oklahoma's made it in the orange. We've been there for a few days, and the rest of the country is moving in that direction as well. And globally, the United States is in the orange, and is looking okay. The Eastern Europe or Western Europe is still struggling, and the Central Europe as well. So we'll see how that develops as the seasons change, human activity changes, and then the vaccines coming through the back door. So in Oklahoma, the numbers are plateauing. I think the numbers that came in just a little while ago, things trended up a little bit, but we're averaging about 18 cases per day per 100,000, or 736 cases per day. So again, you can see this first 2 weeks of January, we really got hit hard, and then a very rapid recovery. Deaths in Oklahoma are trending up just over the last couple of days. Today it was reported 38 deaths, which raised the average a bit to, I think, 27 deaths per day. So again, hopefully those will start trending down. The only issues I have with the state data really is some of the case reporting. Some of the cases can be really old, anywhere from 15% to 45% of the cases reported on a day might be more than 2 weeks old. So interpretation of those data can be difficult. So we just try to look at the trends and see what's going on. And in the state, the number of people hospitalized likewise has plummeted, thankfully. See, back in when we had our first surge, we were at about 600 hospitalizations per day, and then the second surge pushing 700, and now we're back down to less than 600 people hospitalized with COVID-19. So again, going in the correct direction. The numbers specifically for the Tulsa hospitals are likewise following this trend. So if you look at Oklahoma, using the same criteria as that national map that I showed you, Sequoia County in our area is still in the red, but they're trending down, in Tulsa and Washington County as well. So things are improving. We've got a lot of yellow in our less populated counties and moving in the right direction. You know, flu has been very gracious to us this year. Really hasn't been had a huge impact on our healthcare delivery system. If you look at the numbers on the bottom, this is since September 1st of last year. We've had 161 people hospitalized with influenza compared to almost 19,000 for COVID-19. And likewise, the number of deaths from influenza. You can compare annually what we normally see. Last year, 3,500 hospitalizations and 85 deaths, and so on in the last 3 years. So the measures we've taken to prevent the spread of COVID-19 has had a huge impact on the flu. And likewise, the human body rarely will be infected with 2 different viruses at the same time. So that's had an impact. Now, Cherokee Nation, we're approaching 15,000 total cases. This graph is cumulative. And so the bars are the cumulative total for that day. And then the black line is the current number of active cases amongst our patients. We're averaging about 17 cases per day. The next slide's a little more intuitive. You can see back in December, the beginning of January, we had 523 cases in one day. And the 7-day moving average, you see, rapidly decreased. Now here in the beginning of last week, because of the snow, we did very little testing and didn't get many cases, and we kind of caught up after that. Today's total is now up to 16, so that 10 is a 16. And our average is about 18 cases per day. I expect that to go up a little bit as this testing, the low numbers from last week are replaced by the numbers this week. So we've really suffered greatly in December and January and into February with our hospital services. We're overwhelmed like they were in the state, but we manage extremely well. And we're moving in the right direction. So the number of cases per week, last week the number was pretty low again because of the weather, and this is just through yesterday, the 41 cases. So that will go up a little bit. But you can see how desperate we were for 5 weeks in a row. We had more than 1,000 cases per day. So really, really difficult and a challenge for us. Now, one of the ways we figure out if we're doing enough testing, we're offering drive-through testing Monday through Friday in the mornings at all of our healthcare facilities. And this week, our positive test rate's down to 5.5%, and which is a tremendous difference from what we've seen the last several weeks. So that's telling us that we're capturing a lot of the cases that are out there, most of the cases, and that our contact tracing, the quarantining and isolating that we do will have an impact on the spread of the virus. This is all really good news. If you zoom in on Northeast Oklahoma, these are state numbers. This is not Cherokee Nation Health Services. You can see the numbers a little bit more clearly. I think we'll have more counties in the yellow in the next week. My only concern is that with the weather improving so much that we're going to have more community spread as families and different organizations get together. You know, the stories I hear from the several different communities is that masking and distancing just aren't a thing anymore. People aren't doing it in some venues. So I'm a little bit concerned about that. So we'll see. But you know, orange is not great. It means that there's widespread community transmission. But again, our trends now are either going down or remaining steady. Now, all these data are available on our dashboard that's updated Monday through Friday. And the links are at the end of the show, but it's publicly available data, and you can peruse that. The data are updated by noon, Monday through Friday, so you can see how your county, your area, your district is doing. Now, you know, with what I'm sure you're hearing in the news and with the state epidemiologists and what we're really preaching here at Cherokee Nation Public Health is that we need to keep doing what we're doing. This layered effect of all the mitigation measures we have to reduce the spread of the virus is hugely important. You know, before you leave your house, you need to know your risk, where you're going, what you're going to be doing. Still need to wash our hands. We still need to wear a mask. Taking the test, it gets a little bit confusing with spring break coming up and people getting out of their houses more. The recommendations are pretty clear that if you're going to go on vacation, and get tested before you go. And if you're exposed to many other people, then when you come back, wait a few days and get tested again. Be very vigilant for symptoms. If you've been exposed to someone that you know is tested positive, go get tested. If you think about where we were at the beginning of last summer, getting tested was difficult, and now we've got the test. We've got the staff and we've got the technology and the supplies to test people if they come to get tested. Watching your distance has a huge impact. And then the vaccine. So Cherokee Nation's been held up as a model for vaccine distribution. And it's really amazing the amount of effort it takes to do this well. And Cherokee Nation Health Services has done that, so you'd be very proud of that. And it's really the do your part. Our communities, the actions that I take regarding COVID-19 affect my whole community. And as leaders in our community, we need to do that. So there are a lot of analogies with cars, and I really like them. I've been vaccinated. I was very excited when that opportunity came. But just because I'm vaccinated doesn't mean I can ignore everything else. And it's a little bit difficult to understand. But when I think, this morning I wore my seatbelt in my car on my way to work, and that seatbelt protects me from dying and getting seriously injured if I'm in a car crash. But even though I had on my seatbelt, I still stopped at all the stop signs. I used my blinker when I turned, and I drove the speed limit, and I paid attention. I didn't play on my phone. Because all those things layered together protects me and it protects everyone else on the road. And COVID-19 is kind of the same thing. Any one of these isn't 100% to protect you from getting COVID-19 and spreading it in your community. You need to do all of them as much as we can. So of course there's concern about the variants. You've seen that in the news. The big concern right now is the UK variant, the B117. It's been identified throughout the country, and the national epidemiologists are predicting by the middle or end of March it will be the predominant strain. And so kind of what happens when a person is infected with 1,000 or 100,000 copies of the virus, and the virus starts to replicate, there are random mutations in the RNA in the virus, and usually those mutations make the virus less effective and it dies and it doesn't spread. But when you've got millions of people infected with millions of copies of the virus, there'll be a strain that has some advantage. Either it's more contagious, or it lasts longer in the body, or it can cause more severe disease, and that strain will spread. So, in Oklahoma, they identified one case of the Brazil variant, the P1, which was quickly identified, and the person isolated. And that person had a travel history, so they didn't catch it in Oklahoma, as far as I can tell. And so, if you look at this red line, is the UK variant, the B117, that was identified in the United States, and the number of times they've identified it. And the actual number isn't really that important, because we're not doing the RNA sequence on every person that tests positive, right? So these are kind of random samples or public health surveillance. And I was in a meeting with the CDC director yesterday, and they're investing a few $100 million in our national ability to sequence these viruses. So I think most importantly is the trend. You see how quickly it's increasing, and this is the one that the national epidemiologists predict will be the dominant strain in the US next month. Compared to the other strains, the one from South Africa and the one from Brazil haven't spread too quickly. There's more data coming out about the increased contagiousness of the UK virus, as well as the causing more severe disease. So we still need to protect ourselves. The data coming out of Israel is very promising with the vaccine, that it's, they're right up achieving herd immunity, and the number of people being hospitalized with COVID-19 has plummeted to minimal levels. So, when it comes to the vaccine, and some more research coming out that if you've been infected, that you have a high level of immunity as well. As someone who has received the vaccine myself, every time I'm exposed to the virus, I'm giving the virus the opportunity to figure out a way to beat my immune system. And so that's why the other mitigation measures are so important. That if we have half our population immunized or have tested positive and have some kind of immunity, and they don't wear masks and they get together in indoor settings, et cetera, and expose themselves, then we're going to continue to have variants, and that could be very, very dangerous. So when we think about what's risky and what's not risky, this is a very busy chart, but it's really wonderful. That first part of that layered approach I showed you was knowing your risks. So when you make a decision to leave your house and do something, how risky is that activity going to be? And then you employ those mitigation measures to try to prevent infection and spread. So going to work, right? That's this medium to high activity. So in my office, most of us have individual offices, and we keep the door closed. And when we leave our office, we put on a mask and we wash our hands. And when we do chat and we have to talk, we keep 6 feet apart. We do all of those things. When I go to the dentist, right, that's a medium risk. If I go to church, that's high risk. And it all depends, right? How many people are there and how long you're there. Do you have ventilation? All those things that we've been talking about for a while. And then playing tennis or going grocery shopping, that's low or medium risk. So you apply your mitigation measures to those. And if there's something that you have to do, then you wear a mask, keep your distance, wash your hands, et cetera, et cetera. And so don't forget, and you've seen this before, one of the things that's very difficult about this virus, despite that it's so easily spread, is that people are contagious for 2 days before they have any symptoms. And I still hear it every day. So yeah, my husband tested positive, but I'm not having any symptoms, so I'm going to work. And it doesn't quite work that way. So it can be up to 30 days from exposure before you get sick, but 95% become symptomatic within 14 days. And that's why our quarantine is for 14 days. The average amount of time from exposure to onset of symptoms is 5 to 6 days. And that's why we recommend after exposure, you get tested 5 to 6 days after exposure, unless you have symptoms and you get tested then. And then there's some good research that shows that people are contagious for about 10 days after symptoms start. So that's why we isolate people who've tested positive for 10 days from the onset of symptoms. And unfortunately, symptoms can last for a very long time. You've heard about the long COVID syndrome. There's lots of research going on with that. Our doctors here at Cherokee Nation are studying it and learning about it because it's going to become an important part of the healthcare we provide over the years. And then after someone recovers from COVID-19, they're immune, but we don't know for how long or how effective that immunity is. We talk about the COVID vaccine being 95% effective at preventing severe disease. And so in the real world, that's based on research, then in the real world, we're finding that that's holding true. Now, even if if there's a new variant and the vaccine's only 60% effective, it still has a tremendous impact on the ability of the virus to spread and maintaining herd immunity and doing all of that. So what I would ask of you as our community leaders is to encourage people to get vaccinated, refer them to their doctor or to public health if they have questions about the vaccine. Science has done its job. We know how to find the virus, we know how to test for it, we know how to treat it. We develop a vaccine that's effective, the vaccine is available, testing is available. Now it's up to us to grab hold of those advantages we have and use them and make COVID-19 less of a burden on our communities. So I think Dr. Montgomery always asks me when I'm done, so what's the future look like? And I think what will happen in the coming months, in March, we will have a bump. It won't be anything like what we saw after Christmas, but we're going to have an increase in cases, and then things will calm down. In the summer, we'll have another bump as more people are vaccinated, and then it's kind of unknown. And the big unknown is the variants that might emerge and defeat our immunity. And then we'll just have to keep on top of it. Our job in public health and our epidemiology department is to keep track of what's going on, inform our leadership when red flags come up, when there's outbreaks in a community, to identify those outbreaks and help people to isolate and quarantine to try to prevent further spread. So that's all I have, and I'll be turn it back over to the chair and to Lisa.
Chair,
Thank you, Dr. Gann.
Dr. Dobbins.
Or questions?
Dr. Dobbins?
Lisa, do you have something to say?
Yes, I neglected to tell you in my earlier presentation that we are working, one of our cooperative agreements is working on vaccine hesitancy in the community and trying to figure out ways to increase vaccine uptake. And we'll be working on that as well as the other projects. So.
Victoria?
Thank you. This is for Dr. Gann. I was wondering why you think there will be a bump in the summer.
Well, from what it's because of people traveling. You know, people are going to be leaving their safe zone and intermingling across the country. There are going to be people from out of the country coming in and people leaving the country. So it's travel. And, you know, one of the good things about the summer is a lot of activities are outdoors, right? You know, outdoors is better than indoors as far as the spread. But there's going to be large family gatherings and whatnot. So it's people getting together.
Okay, thank you. I wanted to add a comment, and I just wanted to thank you so much for the help you've been to me and my questions that I've had in the last few months relating to family members as well as community members that had questions that you helped me with, and I just appreciate you so much. Thank you.
Thank you. It's very kind.
Dr. Gann, if I could follow up a little bit on that. Have you seen any outdoor transmission rates cited anywhere? It seems like the rate of transmission on outdoor activity would be somewhat microscopic, minuscule. Is it not?
Well, it's less than being indoors, and I haven't seen specific research. The thing is what you're doing outdoors, right? So if it's a family gathering and there's lots of hugging and kissing and you know, sitting around a table closely, if the wind's blowing hard, if someone there is symptomatic and is coughing, you know, so all those things are variables. But we do know that being outside is better than being inside.
Thank you. Denise?
Lisa, you had mentioned the cooperative agreements, and could you give me an example of that? I mean, I know you just said a vaccine awareness or a vaccine hesitancy campaign. Who are you doing those with? Is that Cherokee Nation and the state health departments, or can you just give me some examples of what you're talking about?
Sure, I can. That particular cooperative agreement is with National Institutes of Health. We have also grants from CDC. Most of the grants from CDC are actually cooperative agreements because they outline all of the things that they're going to do and that we're going to do, such as the breast and cervical cancer early detection program, comprehensive cancer program, the good health and wellness in Indian country, our overall public health infrastructure, and some of our surveillance grants are actually cooperative agreements. So we are working on that. With the majority of those funds are federal funds. I believe we have two actual state of Oklahoma grants that we work with. But otherwise, they're all those federal agencies, and those CDC, NIH, National Cancer Institute, and also HRSA are the four that we mostly work with.
Okay, thank you, Lisa.
Harley?
Yes, Dr. Gann or Lisa, you may have said this a while ago, and maybe I didn't catch it, but you said that, I think you said Sequoia County was a high area for the virus, but do we track that? Can we tell what community that maybe is the highest or has the most infections within the Cherokee Nation? Because I know with the old RPMS system we had, it would drill down to communities, and I don't know if Cerner does that or not, but do we have an idea where the most virus is, like Jay, or Grove, or Kenwood, or places like that, or is it just strictly countywide that you keep data on?
We keep data at the county level. You know, when we have individual outbreaks, you know, we don't really map those out. There's a certain church that might have 15 cases in a week. And, you know, in the communities, people travel around. So we haven't found it really useful to say, okay, in Vian, this is where the problem is, or this, you know, in Kenwood or wherever. It might be a school, that this school is having a problem, or this school system. But if you look at the county level where people work and where they play, that seems to be useful enough for us. Now, what we're seeing, most of our spread now seems to be within households, that people go to work and maybe get infected at work. Then they bring it home and everyone in the household gets sick. So we see a lot of that. The schools have done just a tremendous job. You know, they're, you know, especially with their classrooms. Sports is a different story, but we've had several outbreaks on sports teams. But in the schools, they know what to do and they do it well. And, you know,
Dr.
all these
Van?
mitigations we talk about. I'm sorry, Lisa.
And I would just, council person, I think that I can maybe address that. I know with your reference to RPMS and drill down to community, what that function was is a self-reported community. So when you were asked that and it was put in, so it wasn't really linked to an address. So for instance, what I would go in, I might live in Tahlequah, but if someone were to ask me, what is your home community? I would always say Peavine, but I don't necessarily live there, and I don't know how much of that went on. But so if you look at it from a zip code, take for instance, Adair County has lots of communities, but the majority of those communities fall under one zip code. I think there's 3 zip codes in Adair County. So you can, Peavine and Bell are on the same zip code. So it would be a little difficult to look at that, but I'm sure that could be done by zip code at some point. I'm not sure how useful it would be though.
Okay. And just a follow-up question, I think Dr. Gann, you said, and I think we probably all know that the flu has not been as prevalent this year. And do you contribute that to mask wearing, or do you contribute that anything that looked like a flu was listed as COVID?
No, we don't list someone with COVID if they don't have a COVID-19 test. What we would call a clinical diagnosis. So we don't diagnose COVID without a positive test. So I think absolutely all those mitigation measures we discussed, the masking and distancing, avoiding large gatherings, et cetera, has decreased the transmission of the flu, especially in the schools. And then this other idea that you're not going to get infected with both viruses at the same time. So, and we had a good uptake in our influenza vaccine as well. So all those things contribute.
Okay, thank you.
Chief of Staff, did you have something to contribute?
If they're done, I was going to add something at the very end, so.
I don't think they're quite done, but
Yeah, I'll go ahead and wait until they get done.
okay.
Dr. Gann, Lisa, your staff, I appreciate all the work you've done. You know, when our families went through the virus, you were always there to help answer our questions, help make us feel better. Hey, one thing, I may be the only one thinking this, Dr. Gann, and it's nothing negative towards you guys and what you're doing. It just sticks out here. I'm far from a preacher. I mean, that's just a fact, far from a preacher. But, you know, nationally and statewide, you know, there's lots of activities and large gatherings that we're not mentioning much or talking about, but it kind of gets me when the first example of risky behavior, it always seems like it's church. And, you know, you can, with all due respect, you can take this or leave this for me, but I'd like to see us finding another large gathering or risky activity, you know, besides church to start out with. And again, that's not a negative thing, but it's just when I hear it, it kind of bothers me that that's our go-to risky gathering when there's so many gatherings happening that some of those don't get mentioned. So thank you. That's just coming from me.
I understand. I think it comes up a lot, Councilor Crittenden, is because it's so common, right? Now, you know, I know of a PBR event that happened in Delaware County and a boat and fishing tackle show that happened where there were lots of people together and very little mask wearing. There's been other community meetings, but yeah, so I apologize, no offense. But
No, hey,
churches
no
are-
apology needed, sir. I mean,
Okay.
we appreciate you. That's just my stance, and if it continues to be our first example, I'm gonna live with it and still appreciate you. But it just kind of bothers me a little bit when that's the first example of risky get together that we can come up with. When again, there's lots of risky things going on that don't get harped on, if at all, not nearly as much as churches. And that's not aimed at you. It's, like I said, nationally, statewide. So I didn't want you to take that negative towards you, just a suggestion from one guy here. So thank you.
Daryl?
Dr. Gann, did you say you can have the flu and COVID at the same time?
It's extremely rare. So at the beginning of flu season, we did have one case where someone tested positive for both. But what generally happens is that if someone is exposed to both viruses, one of them will win, right, and cause disease. So both viruses won't cause disease in one person at the same time. So extremely rare.
Dr. Gann, how often do we check our citizens just for an antibody test, a positive antibody test? Do we do much of that?
We don't, and because there's really not any clinical usefulness for that. So if you were my patient and I was worried about COVID-19 in you, because you're having symptoms, you're exposed, an antibody test wouldn't give me any useful information to take care of you. Now, there are epidemiologists who do studies to try to estimate the exposure in a population to the virus, and antibodies can help with that. The antibodies tests are not super accurate, and again, clinically, we don't offer that test at Cherokee Nation Health Services because it doesn't help us take care of people.
Okay, if one does have a positive antibody test, is it not medically advisable to kind of hold off on the vaccination for 90 days or even longer? So if you have a positive antibody test, it may not be advisable to go ahead and get the vaccination at that point.
It's definitely not harmful to get the vaccination, right? So at the beginning, when the vaccines first rolled out, we recommended to people that it was okay if you've recently been infected to wait for 90 days. That would, because they have some level of immunity. At that point, we didn't know how much or how good that immunity was. So people with zero immunity would have access to the vaccine. So that recommendation was pretty soft. It's like you can wait 90 days if you want to, but if you want to get the vaccine now, it's okay to do that. Just some research came out this week showing that it appears that immunity from infection is very similar to the immunity one gets from the vaccination. But that still has to be repeated and kind of looked at real world.
Okay, thank you, Dr. Gann.
Yes, sir.
Chief of Staff.
Well, once again, I'd like to thank Lisa and Dr. Gann and that team and in total our entire health team for the work that they've put in. And as you know, this week we've gone out and started serving meals to our healthcare workers to tell them thank you. I've likened this to running and told several people that, you know, we ask our healthcare workers to go run a marathon, and then 9 months later we say keep running. And so they have endured a lot and long hours. fretting over the health care of individuals as well as communities. And so I'd personally like to just say thank you to Dr. Gann and Lisa once again. And then the other thing that I'm going to announce to you at this moment, we haven't made it publicly official yet, but we are running into phase 3 as of today. So phase 3 is any beneficiary, a citizen of a federally recognized tribe, or holds a CDIB with that tribe, is now eligible to receive vaccination through our healthcare system. That is anybody over the age of 16 that can receive the Pfizer vaccine, 18 for Moderna. And so I wanted to let you guys know that we're going to be moving into phase 3. So any of those individuals that haven't been previously vaccinated are now open to receive the vaccine. So good news as we continue to move through that progress. And if you can continue to help us spread the message, let people know that they can receive the vaccine. So that's what I want to update you on. Thank you.
Todd, you said that phase 3, where are we on the phases as far as employees returning?
We are working on returning those employees. Originally, we were going to shoot for a March 1st timeframe to bring employees back, but due to the weather that we had, it messed up our vaccination distribution. So we wanted to make sure that we provided enough opportunity for those employees to get rescheduled and give that time. So we're probably looking at somewhere around March 8th or 15th to begin to reintroduce employees back into the work environment.
Todd, I just want to make sure I'm clear. You said beneficiaries. Now, that doesn't mean a non-native spouse. Does it mean a non-native spouse?
No, not at this point. So just to, as Dr. Gann suggested, tell you what's next. We are seeking permission from Indian Health Service to make sure that we can vaccinate a non-beneficiary household member. And if you've watched and kept track of when we introduce our next phases, it's typically about 7 to 10 days, and then we will move into a next phase. So we are making plans to try and introduce that to non-beneficiaries, but we want to make sure we extend those to our beneficiaries and make sure we've got IHS approval to use that vaccination on non-beneficiaries of the IHS system before we move forward.
I've had several calls.
Yeah. We've been asked that question by several council members, and we're trying to accommodate that, and we just want to make sure that we're okay before we make that announcement and are able to do it.
Sure. All right.
So Todd, does all the clinics have both Pfizer and Moderna, or do you just have to take whatever the clinic has?
Yeah, so our clinics, the larger clinics of Tahlequah, Veneta, Muskogee, and Salisaw have cold storage, the ultra cold storage available to house the Pfizer vaccine. So those clinics are offering Pfizer. The other clinics in Jay and Salina and Stillwell and Kuiskui and Nowata, all of those other clinic sites are offering the Moderna vaccine because it's easier to handle. So it's based on our facility demand and capacity, and then the equipment that we have available in that. So, so we'll try to match them up as best we can. And of course, if you watch the news, there's hope that we'll see a third vaccine that's available, which is Johnson & Johnson, by hopefully tomorrow to receive the EUA, and we'll see what that looks like, and then we'll fold that into our plans as well in the future.
Quick follow-up, Todd. So today's a big day then. So someone says, Sean, when can I get my vaccine? Can I tell them, if you're 16, hold a CDIB card, call this number, right?
Yep.
And now will our people say, hey, they'll direct them, if they're 16, they'll direct them where the 16-year-old shots are, right?
Yep.
And if
Yep.
on the other end, they'll
Yeah,
realize
we'll
what.
have to make sure that based on distribution and age and where they'll be routed to, but yes, we will make sure that they get the correct vaccine.
Okay, thank you.
Yes, Todd, is the third vaccine by any chance going to be a single shot?
That is our understanding, yes, and the way it's been tested and the way it's been, developed, it would be a single shot distribution. And the handling of it is even easier than the first two, so its efficacy is a little different, and it's a little bit different, vaccination, but, I think it would be useful in our arsenal to fight COVID-19.
Thank you.
Counselor Shaw? We're
Thank
re-
you.
Yes.
I want to say, first off, that I think that an outstanding job has been done on this totally, and I want to say thank you to all our healthcare workers. But my question, I'm not sure who to address it to specifically. Do we want to receive the Moderna vaccine, and do we have a choice in that? Because it's not as effective as the other two are, do we have a choice?
I don't know if
Gann,
you guys want to take a pass at that. We do have a choice in whether or not we choose to receive that. And that'll, that's one of the things we've been looking at and evaluating. We're, obviously pending the EUA from the FDA to make sure that it's going to be approved for use. And so we're waiting to see what that's going to be. The other drug that was out there, the AstraZeneca drug that was out there, its efficacy rate was in the 50 percentile range, and we had really made that assumption that we probably wouldn't use that if it was made available to us. So once we get a little bit more details and we see what the FDA approval looks like, we'll be evaluating using the Johnson & Johnson vaccine.
Thank you.
So is that going to be announced today?
Yes, the press release will be sent out and posted on social media later on this afternoon. It may be going out as I speak, but I wanted to let this body know in advance since we were looking at announcing it today.
Be good.
I heard the term CDIB used by you and then by Sean. Tribal membership is different than CDIB. Can you clarify?
Yes, so tribal membership or citizenship means that you're a citizen of that nation. A CDIB is Certificate Degree of Indian Blood. It's a card really used by the 5 civilized tribes here in northeast Oklahoma. And that delineates your connection back to, or your percentage of blood quantum of that tribe. You could have blood quantum from multiple tribes. But from IHS, to be considered a beneficiary or a recipient of services from an IHS facility, you either have to be a citizen of that tribe, or if you're not a citizen, you at least have a CDIB showing that you are of direct lineage to that tribe or a tribe.
Okay, but any citizen of the Cherokee Nation is a beneficiary.
Correct.
That's the part I wanted to make sure was said.
Yes.
Thank you.
Okay, before we let you go, Lisa and Dr. Gann, would it be possible our next public health subcommittee meeting, could we get the conclusions from the OU health survey? I guess that contains our physical activity survey, and what else did it have? The just overall health survey, I'm sorry. Would that be possible for you to bring that before us next time?
Dr. Gann, I'm sure that it's possible, especially for the entire area. And then as we're working on the counties, I don't know that all the counties can be done by next time, but it's a possibility. And I would defer to Dr. Gann for the time on his staff and what it will require.
Okay, thank you, Lisa. Thank you, Dr. Gann, for being with us today. Are there any other questions? Thursday, April 29th at 11. Are there any announcements? Any further announcements? I would entertain a motion to adjourn.